1 in 8 women will be diagnosed with breast cancer during their lifetime, posing a major burden on patients and the healthcare system alike. With recent medical and surgical advances in breast cancer care and departure from the principles of Halsted, the role of contralateral prophylactic mastectomy, or CPM, has become controversial. While CPM is known to reduce the risk of contralateral breast cancer by 90%, the risk of death from a contralateral primary cancer remains low, calling into question the utility of CPM. However, qualitative literature supports the fact that some patients choose CPM due to concerns about costs of future screening, desire for chest symmetry, and peace of mind. Notably, rates of CPM have historically been disproportionately low among racial minorities in the United States. While many have postulated the role of structural factors in such disparities, hospital-level differences in practice patterns have not been studied thus far. Therefore, we examined variations in the practice of CPM at hospitals treating a varying proportion of Black patients. This was a retrospective cohort study using the 2004 to 2020 National Cancer Database. Hospitals in the top quartile of the proportion of Black patients served were considered Black-serving hospitals. We noted Black patients to have lower risk-adjusted odds of receiving CPM relative to white patients. Additionally, both Black and white patients at Black-serving hospitals were less likely to receive CPM compared to their counterparts at other centers. On Kaplan-Meier analysis, those receiving CPM had 82.9% overall survival at 10 years, compared to 66.7% among those who did not receive CPM. While it remains unlikely that this is due to an oncologic mechanism alone, such a survival difference should not be ignored. We have 3 main takeaways. First, racial disparities at the patient and hospital level may be responsible for the lower observed rates of CPM among Black women. Second, the lower likelihood of receiving CPM at Black-serving hospitals may indicate the presence of structural differences at the hospital level. Care should be taken to ensure that all patients at all hospitals have the opportunity to engage in shared decision-making regarding such treatment options. Lastly, despite the debated value of CPM, the present study notes greater overall survival among its recipients, such that Black women undergoing CPM live longer than white women without CPM. It is plausible that patients with access to CPM may have globally protective characteristics which may reflect key metrics of privilege, including trust in the medical system, social and educational capital, and strong personal support systems. Our findings indicate such factors to have important links with race. Ultimately, systemic solutions are needed to address the continued racial disparities in CPM access and breast cancer care. On behalf of our team at UCLA, we are grateful for the opportunity to share our work.